Disclaimer. Oh yeah, I'm gonna record. Oh yeah, just click OK. Yeah, I'm gonna split this up into kind of lung cancer and laryngeal cancer, and then I have another one for the kind of the pleural space, pulmonary embolism and stuff. Just m- spend them just kind of separate them out. If we do this really fast, maybe I'll kind of pop in and do the other one, I guess. Just like maybe start it. Depends on what the vibe is. Okay. But with lung cancer, I kind of just wrote out some general information just to start. Just that tends to a lot of people tend to come in with late symptoms, and they might be treated too late because a lot of the symptoms that make people want to come in end up being like coughing blood and some of that lung pain. And that at the time that starts kind of popping up, it might be a little bit on the later side. While some of the early signs might be very basic and generic, like coughing and stuff, especially people that are high risk for lung cancer, like people that smoke, they can have smoker's lung to begin with, so they might not really think much of it. So some of the symptoms, they might not really think too much about it. General and the more general information is that it's able to metastasize to the bone, liver, brain, adrenal glands. Just general information. Don't really need to go too hard on that. But there are two different types of cancers that we're going to go through. It's the non-small cell lung cancer as well as the small cell lung cancer. Um, so they do differ in like a few different ways here. Um, This one, how would you say that it grows and spreads? Like between non-small cell and small cell, which one's faster, which one's slower? Yeah, this one's more slower. So this one grows and spreads more slowly, while this one's going to be more fast growing, spreads fast, and it's also more aggressive. So how I think of it is just kind of, yeah, less survival. Yeah. So I think of it like small cell, smaller chance of survival. That's how I think about it. So small cell, small chance of living. So I think of it that way. So that's how I kind of get in my brain that this one's going to be more aggressive. It's going to be just a little bit more crazy, more stuff going on than the other one. So let's see what we got. Stage 1 and 2, higher chances of survival. Yeah, so that's gonna be something that's mentioned here for non-small cell. The 1 and 2 have better chances for survival. Stage 3 can be cured in some cases, and stage 4, um, it's gonna be a lot harder. In terms of treatment, what do you guys think about for non-small cells?
Chemo and radiation.
Yeah, so this one's yeah, this is probably between the two, this one's more likely um to include chemotherapy and surgery as well. This one's uh the more likely to be able to be used just like with surgery as opposed to small cell. Small cell might be too aggressive for surgery to help, so it might require radiation and chemo. But the non-small cell, we might be able to, yeah, we might be able to utilize radiation, chemo, or even just radiation, and then follow that up with surgery. So kind of help to prevent the spread with radiation, maybe make some progress on the tumor, and then excise it out. With the small cell, it's a little too aggressive, so more likely that we're gonna need to use chemo, or we're definitely gonna have to use chemo just because it's a systemic way to treat it, and less likely for surgery to be effective. Although we can use chemo for non-small cell if surgery is not possible, so if metastasis has already happened. So this one, I would say, radiation and surgery are the most common treatment, and Chemotherapy can be used alongside radiation if surgery is not possible. So that's kind of when metastasis has already happened. Yeah, so the chemo, yeah. So chemo, it's systemic. So radiation localized. There's different types of radiation. You have the internal, external, but the radiation considered more localized. Chemotherapy more systemic. So if you have that cancer spread around to different parts of the body, makes sense that you'd want to use the systemic one because then it hits more areas. Um, so that's kind of like a minor review from cancer in general. Just chemo, systemic radiation, more localized. So if it's like a tumor in the lungs, localized tumor in the lungs, you can use localized radiation, try to both kind of stop the spread, but also kind of maybe decrease the size of the tumor and then excise it. So you'd have to lose less of the lung tissue. And then chemo would only really be if you're not able to do surgery without essentially having to do a whole bunch of stuff because it's spread to different parts of the body, such as like you said here, the bone, the liver, the brain, and so forth. While the small cell cancer is essentially always really going to need chemo. So probably radiation and chemotherapy are needed because it spreads so quickly in the body, so less likely for surgery to be effective for small cell lung cancer. Okay. So, what are some general things? We talked about smoking. That's probably going to be one of your more obvious ones there. What are some other things that might lead to lung cancer? So carcinogens, yeah. And a lot of there can be a lot of that in like cigarettes as well. Yeah, secondhand smoking can include that. So secondhand smoking. Yeah, so there's some genetics with it. Asbestos is another one that I think is worth kind of keeping in mind. So asbestos, pretty much, yeah. Yeah, essentially, yeah. So a lot of anything that can cause stuff like that. Yeah, mesothelioma, yeah. So asbestos, thelioma. Yeah, yeah, yeah. So repeated exposure to, yeah, it's not like you touch asbestos once and you have lung cancer or anything, um, but yeah, it's like repeated exposure. And kind of just keep that in mind. Yes, yeah. So that's a good thing to keep in mind. So a lot of homes used to have asbestos in them. So homes that are older than a certain year, so I guess the 1970s, sounds about right. They might have asbestos, so you might be exposed to it without knowing. So your main prevention, we talked about smoking a lot, and I know you guys know this, so reduce smoking is going to be a key thing to keep in mind. Um, what else can you guys think about? Yeah, screening, essentially, yes. So screening, PPE, I like that. So essentially, for those that are going to be exposed, everyone working in the mines, um, can do things to try to decrease their inhalation of pollutants and stuff. Identify who's at risk. Um, that's just general idea. So again, this is just general idea. I think if you were to take the main thing here, just kind of understand the treatments and the difference between which one's faster, which one's less fast and more slow and controlled. Okay. And some of that screening can include things such as, I think we will talk about it a little bit in further down in diagnostics, yeah. Uh, but yeah, so the CAT scan, CT scans, chest X-rays. So we'll talk more about that there. But those are some of the examples of diagnostics that can be done. So there are some warning signs. So there's early vague signs of respiratory start. So yeah, the smoker's lungs, we talked about how that can be an early sign. So I kind of split it into like early or vague, late signs, and kind of just general stuff. Early, I would say some of the early vague stuff is yeah, like the smoker's cough, um, shortness of breath and stuff. Late signs, coughing up blood is probably closer to a late sign than anything. So that's hemoptysis for the specific word in case they use the technical term. We said hoarseness, so yeah, hoarseness can be an early sign of lung or even the laryngeal cancer that we'll go over more. But that's some of the early signs can be that. What else did you guys mention? That's pretty much it for now. Anything else you guys can think about? So, let's see. Bloody cough. I'd say bloody sputum. Same thing, but kind of the same idea. I like a purulent sputum. Yeah, sure, I'll do that. Kind of it goes with so there's some general signs of cancer. So like weight loss and fatigue goes along with it. Chest tightness, yeah. Surprised no one said shortness of breath yet, but yeah, that's a potential sign. Or like kind of related to anorexia. Boop. Can also think about maybe some wheezing and stuff. Changing cough. We kind of already talked about the changing cough. Um, yeah, wheezing, dyspnea, labored breathing. Yeah, that's kind of what you want to think about. You can have some wheezing here. Yes. So here it kind of goes into the general, because that kind of just goes with cancer in general. You'll have less endurance and stuff like that. All right. Yeah, so fatigue kind of goes with that, so less endurance. Oops, spelled endurance wrong. Okay. Another thing that maybe can be good here, kind of goes with the purulent sputum, maybe pleural effusions, like frequent, recurrent pneumonia and stuff. Kind of goes along with this though, with the purulent sputum. Yeah, like increased risk of respiratory infections. So makes sense. Like everything's kind of going down. And then some of the early vague signs would be the coughing, some hoarseness, maybe occasional shortness of breath, especially when doing exercise and stuff, wheezing. Again, they can be vague because people that smoke a lot, again, the people that work in the mines or work in whatever, they are more likely to have this happen anyway, so they just kind of ignore it until some of this stuff starts happening, and then that's when they get checked out and they find out it's over. Well, not over, but they find out it's probably stage 3 or more by that point. Superior vena cava syndrome. I'd say that's more like a complication. We'll include that somewhere later down the road. Any questions on anything here? There's more symptoms, and here I have some like depending on the site and size of the tumor. They have like that section where it's split off into 3 different pieces. Anything else though on anything we talked about? Just getting the general information out of the way. Again, your focus will always be on interventions and stuff like that. Although you can always get those Um, those like select all that apply, what signs and symptoms and stuff. So that's why it's always good to go through that. But again, interventions is usually your focus. All right. So then he did mention stuff about how the size of the site of the tumor can also the size of the tumor will also impact, the site will also impact. And I do have a picture that goes along with it, but what do you guys think about when the tumor's in the upper lung versus the bronchi versus some peripheral? There's a few different symptoms that go along with it. Let's kind of just do upper lung for now. Yeah, this one's more associated with pain, pain and nerve damage. So this can cause severe shoulder pain, radiating pain. I'll say severe radiating shoulder pain due to uh pressure on nerves. Superior vena cava syndrome. That's like a complication caused by I mean, I guess depending on where it is. I could see that being related to this, because what does upper lung mean? I have a picture here. When they say, because I know we have one that's upper lung, one that's bronchi, one that's peripheral. These two are referring to internal. This one's referring to external. So here's
Muchachos,
a,
todos friends,
oh, what happened?
¿no?
Oh, just unmuted. Okay. Um, here's what they mean by the upper lung. Because initially, like when I heard that, I was like, he didn't really go into too much detail. And again, you don't have to be an expert, but it's just like the upper lung one's referring to outside of the lung here. So here they call that the Pancoast tumor. You don't need to know that. It's just um kind of you can see here the tumor on top of the upper lobes can interfere with nerves, blood vessels, and stuff. So I could see well, I guess the heart would be here. So I guess it wouldn't really spirit vena cava syndrome. I mean, I guess if it's on the outside and stuff. And then here you can see this is the bronchi one, the bronchi location of the tumor here, the central lung cancer. And then here would be the location for the peripheral. So it'd be literally on the little peripheral, little bronchioles and stuff, like closer to the alveoli sacs. So that's the peripheral. Here would be the bronchi, which very much on the large bronchi trunks here. And then this is the upper one where it can interact with nerves and stuff. So we did mention that, and Kevin did mention the drooping eyes and stuff. Yeah, that's something that can happen again from nerves. And then what about the bronchi one? So Ryan mentioned the labored and painful breathing. I think that can be, yeah, that could be something that happens for sure. Like you can have that painful wheezing thing, but I think like you can maybe consider that as just being like a general thing that kind of goes with some of these. I'm sure there's more specific stuff, but don't really need to go that detailed. But there's a specific thing to look out for when it's in the bronchi location. Yes, yes. So dyspnea slash tachypnea and obstruction. So that's where you have the wheezing and the stridor. So that's how we know that potential airway obstructions happening. So that tumor is causing obstruction of your ability to breathe. So you'll have more of that wheezing. And if you have stridor, then that's really bad. And that means the obstruction's like very close to fully closing. And you know that's one of your ABCs, so you gotta do something about that. So that's kind of like the big thing to think about. So if you hear stridor, you hear wheezing, some things to think about, worrying about their airway, especially stridor. So that should be always an emergency. And what about when it's peripheral? This one's more likely to be can be completely asymptomatic. But kind of like you guys mentioned here, some of the general stuff would be maybe um they call the pleuritic breathing. So that's the pain when breathing. Pleuritic pain. That's pain when breathing. Yeah, they might not even know they have cancer, and then it might be too late. It's by the time they get symptoms, then they will probably already be at a later stage, have a lower chance of survival. So let's see here. Wait, there we go. Yeah, that's kind of how to split it up. Here you can kind of make sense that late stage is gonna have bloody stuff happening, infection stuff happening, and early's a bit more vague. And I think the difference between these can come up, especially just for sure no stridor. You need to know what that stridor is like in a potential emergency, airways closing. Here, like I said, I have the pictures of the locations. It makes it easier for me to remember and try to make sense out of it. And here I wrote down the stages. I don't recall knowledge of the stages being too important. But they're here for reference. So stage one would be if it's only in the lung, less than 3 centimeters. Stage two, more than three, less than seven, and includes the lymph nodes at that point. Stage three, it's including lung and lymph nodes, and it's going to be more than seven. Or it could be under seven, but affecting multiple different lymph node nodules. Stage four would be any size of tumor, um, but it's spread outside of the lung, so that can be bone, liver, brain, adrenal gland, but don't focus too much on the hyper details. Like I said, I don't recall this being too important. And then meanwhile, the small cell lung cancer only really has two stages according to what we went over, which kind of makes sense because we know this one's faster growing. So it's like the stages would get blurred. So it's just kind of limited versus extensive. And again, don't focus too much on this stuff here. But what is, I think, important to know would be some of your diagnostics. So we did talk about the CAT and CT scan, and the chest X-ray. But tell me what you guys know about one over the other, and maybe other diagnostics as well that you guys can come up with. Yeah. So won't show unless the nodules are more than 1 centimeter. So it's not going to be a reliable one for cancer. If someone comes in with a lot of the respiratory symptoms, they'll still do it, of course, just to rule whatever they can out. But if they have a cancerous tumor that's smaller than 1 centimeter, it's not really going to be visible. That's where the CAT scan and the CT scan can come in. So they can show tumors anywhere for the lungs there. Kevin mentioned the bronchoscopy. From the bronchoscopy, what can we do? Yeah, visualization of the bronchi. Yeah, you can do the biopsy, visualize, get samples exactly. So this is going to be one of the method that you're going to be doing. Well, you're not going to be doing it, but a method that's going to be done to get lung biopsies from lung samples for biopsy. So that's going to be where, again, your biopsies are always your gold standard and stuff. But knowing that your chest X-ray is not as important, just at least purely for detecting cancer, because it won't catch ones that are still kind of growing out stuff. Anything else that might be something that they could do? So at this point, we kind of got a lot of the lungs themselves covered. What about for other things outside of just the lung area, like spreading and stuff? There's also the thoracoscopy, yeah. So that's another thing. So, yes, cancer markers. Yeah, I don't remember the name of the cancer marker for this one either. It's not particularly important, I don't think. You can get a sputum culture, yeah. Sputum culture is good. Mentioned the labs, the bone scan, yeah, bone scan. Check for mets to bones. We said ABGs, I like that. ABGs, general generic labs. Yeah, if they do have a thoracentesis, then yes, they can do yeah, I like that. Thoracentesis. And they can also do an analysis of that effusion sample. Thoracentesis. I like that. Effusion for sample. But that bone scan. There's another one that's good for meds. Like a more general one for meds. Metastasis. The MRI can be one that can be there for here. Like you can kind of include it with your CT scan. The PET scan, yeah. So that's another one to keep in mind. The PET scan is gonna be there to detect metastasis. That's pretty much that. So I think this is key to know. Yes, it's the radioactive sugar injected IV. Um, and once they do the scan, if there are spots that light up, kind of shows potential for metastasis. I believe the idea there would be that, you know, your cancers try to create their own blood supply and nutrition supply. They become independent, and essentially that's what that tumor is. They're basically like growing their own little base of action. So they're using up the body's resources. So the radioactive sugar can show up on tumors. So that's kind of where that comes from. For that's you don't need to know the way it works. You just kind of need to know that it can detect metastasis that way. Since it's radioactive sugar, this one I'm not actually sure because I'm not sure if they use I mean, it's radioactive sugar, but I guess the contrast. It's a good question though. I'll look it up. Let's see. Okay. Radioactive fluorine rather. Let's see. Doesn't seem to be the case, no. The tracer doesn't contain iodine. Oh, it's fluorine. I just said it was fluorine. Yeah. I went into a deep dive for no. I went to deep dive. It told me it was a isotope of fluorine, and then I was like, is this iodine? No. Yeah. So let's see. Iodine allergy not relevant for s- contrast. Good question though. I like it. Okay. And then there's some more stuff I guess we can go over for the bronchoscopy. Just kind of general stuff. They focus a little bit more on the bronchoscopy. Let's see if I already have a. No, I don't have a section for it, so I'll just make one. We do want you to really understand that one. So we already talked about what it's for. get tissue visualized directly, the bronchi. Uh, Probably just, your standard pre-op is your MPO, informed consent. There's conscious sedation with Versed or fentanyl, propofol. Yeah, he does say remove dentures. Interesting one. Do be making sense though. And your post-op, I don't think there's too much that's out of the ordinary. It's pretty typical pre-op, post-op. So you're gonna assess for the gag reflex. You're gonna monitor vital signs and every 15 minutes for the first hour, and then keep advancing that until you're able to determine that everything is more stable. Um, yeah, it's pretty much. There's really not too much to it. It's pretty standard pre-op post-op. Yeah, I know a lot of you guys really want to talk about superior vena cava syndrome, so that we can. So we're gonna go over that, the paraneoplastic syndromes, and then we can go over the management stuff. And yeah, there's not too much else other than that. It's just that management. Oh, I get like a little tiny review of chemotherapy and radiation, surgical management, laryngeal. Yeah, that's not too bad. Honestly, I think we're on a pretty good pace, so maybe we'll get on maybe we can do a little bit of that pleural space stuff. 'Cause I think that one's a little bit shorter. All right, so what do you guys know about superior vena cava syndrome? Yep. Yep. So yeah, essentially it's your tumors pushing up on that SVC, decreasing the preload to the heart, the preload of the right side of the heart. Yeah, you can see JVD. So it's going to cause a lot of general swelling, starting with like the periorbital. So that means around the eyes. You'll start seeing in the face, the neck. So what happens when you have all of that backing up of fluid in the neck area, neck, chest, face area? You're gonna have potential risk, yeah, airway obstruction. You're gonna have issues with perfusion, can have altered level of consciousness, difficulty breathing. So a lot of that goes into either dizziness. You can have stridor because of the airway obstruction, wheezing. But you'll definitely have a lot of upper body swelling, so it can build up over time. And this one could be pretty difficult to treat. I think a lot of times it might be like palliative care is like most you can do, like try to apply radiation to the area, and hopefully that kind of minimizes some of the pressure placed on the superior vena cava. Leading to swelling. So it starts periorbital, face, neck, chest, and they can lead to some signs and symptoms, including altered level of consciousness, headaches from pressure, dizziness, dyspnea, wheezing, stridor. All the potential bad stuff happening. Um, so airway obstruction there. Yeah, it's pretty much that. And lastly, there's also the paraneoplastic syndromes. So things that some of the things that occur due to release of hormones. So some of the cancers can also release their own little hormones. And some cancers release different ones. The ones they want to go over here includes things such as, and you guys will tell me, ACTH. Yeah, so that would be the one of the adrenal hormones that can cause Cushing syndrome, and that's something you'll go over in week 7, I believe. ADH. So this you have this one. Lung cancers in particular are are more likely to lead to SIADH. So that's the one where you have a lot of antidiuretic hormones. So you have fluid retentions, you have increased release of parathyroid hormone, so that increases your calcium and stuff. FSH, your follicle stimulating hormone, so that can lead to estrogen release. Oh yes, and then the ectopic insulin is also a big one. So they can release its own insulin, and then that might lead to hypoglycemia. So we'll kind of write all these down. So I would say focus more on the end result more than like the names of the stuff, I think. So like the end result, like what is the symptoms that you have? So increased ACTH, Cushing syndrome. This one can lead to like a moon phase. You'll learn more about this. There's least a lot of stuff actually. Just kind of think about that stuff. I'd say the ones to focus on probably the ADH, parathyroid, and the ectopic insulin's probably the top 3. Yeah, so actually the steroids, Cushing's disease, Cushing syndrome, you can get Cushing syndrome from too much steroid use as well, the corticosteroids. That's something you guys go over in the following week, or I guess for you guys, 2 weeks from now, week 7. So increased ADH can lead to SIADH, so that's the syndrome of inappropriate ADH release. I like to think of SI for soaked inside because you have a whole bunch of fluid retention. So that's the key thing there is FBO, fluid retention. So SI for soaked inside. And that's going to lead to that fluid retention is going to lead to things like decreased urine output because you're retaining so much, and decreased sodium, so hyponatremia, because you're retaining so much. And the key thing about antidiuretic hormone is that it leads to the reabsorption of fluids of water only. So unlike a lot of things like diuretics, which affect sodium, and then the sodium affects the water, this one affects just the water. So yes, so you'll have dilutional hyponatremia because you will be retaining fluids without having an effect on your electrolytes. So dilutional hyponatremia occurs. So we also said parathyroid hormone. So parathyroid hormone's there to help control along with calcitonin, control the calcium in the blood. So this leads to increased calcium, and that leads to hypercalcemia. And hypercalcemia with a lot of your electrolyte imbalances, you can kind of a lot of time generalize it to potential risk of heart dysrhythmias. But for now, hypercalcemia, and then not pregnancy. I was, uh, we're tutoring second semester. That's an OB. I just saw ectopic. I'm like ectopic pregnancy. Ectopic insulin, uh, meaning it's insulin that's coming from somewhere it's not supposed to come from. So ectopic insulin, hypoglycemia. So this is the thing you want to think about here. These are the potential things that can come up from the release of hormones due to the cancer cells trying to set up base. They're trying to get nutrition, releasing their own hormones, trying to be their own boss. Okay. So now the goal overall when it comes to the lung cancers is, of course, curing, increasing survival, enhancing the quality of life through palliation, and then we also have like surgical versus non-surgical as methods of treating it. So when it comes to the surgical management, I think that's going to be the main focus here is going to be the two different types of surgery that they go over. And which ones are those? Yes, you have the pneumonectomy and the lobectomy. So what's the difference between the two? Yeah, lobectomy is removal of a lobe. So remember your lung is consisting of a few lobes. So not even lobectomy, or just lung lobes should be fine. Here's the different lobes. You have the one on the right has three lobes, the one on the left has two lobes. So a lobectomy would be a removal of one of the lobes, and then pneumonectomy would be the whole lung. All right, yeah, so don't get that mixed up because they also have different little quirks with them, and I will go into more detail. Yes. Yeah, if you don't have a lung, you can expect there to be no lung sounds on that side. If you have a pneumonectomy, yeah, because it's not there. I don't know who said it. I think Jim said it, Mr. Robbins. I think he said he had like a student, or something like that. I think one of the teachers had a student that told them that they had like clear lung sounds bilaterally. The left side of the lung sounded good, and looking at the history, they had like a left pneumonectomy, so like they didn't actually listen because like there was no lung there. And then the non-surgical, we've been talking about radiation chemo. We'll go into more detail with the here, just like a quick review of radiation and chemotherapy. Use the markers for external. Oh yeah, you mean like or do you mean the internal? Do you mean use the markers for external patient teaching? What's
when
that
they,
referring to?
when they do the external radiation, basically it's localized. So when they mark the sites of when they're doing the external radiation, you don't want them to remove that. So it's more of like a patient teaching.
Oh, okay. That makes sense. Oh, I like that. I'll include that, yeah. I don't know if we have that on here. Patient teachings. I guess I'll include general concepts, patient teaching. Or I guess I could do it here. Makes sense. Ba, 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 ba. Sure. I like that. That makes sense. Leave the area marked, the markers that are there. All right. Yeah, just like a quick review. We talked about chemotherapy, systemic, used especially for rapidly spreading, growing cancers. Um, some of the signs and symptoms to always think about with chemotherapy, again, is the pancytopenia. Always have to think about that when it comes to the chemo. Things such as nausea, vomiting as well. You're gonna be immunocompromised. So again, the pancytopenia is immunocompromised. The leukocytopenia, this is like anemia and thrombocytopenia. So more prone to infections, anemic, more prone to bleeding, nausea, vomiting. Other general things that could happen, alopecia, so that's the losing your hair. Yes, mucositis is huge for that. because then that causes a lot of pain, can make it so they don't eat. So not only do they lose appetite a lot of the time, but then they don't want to eat because it hurts. Things such as peripheral neuropathy. Yeah, that's true. The metallic taste. So then for radiation, some things here, the metallic taste. And here also fatigue. So fatigue kind of goes for both of them. That can also kind of go with the anemia because anemic people can have fatigue. So this one also fatigue, taste changes. You can have esophagitis, so inflammation of the esophagus, depending on the area. And obviously, if you're doing it for lung, then you're going to be getting closer to that area. So it can cause specifically like inflammation of the esophagus, which can make things differently to eat, difficult to make it more difficult to swallow food and stuff. Swallow food. So, some general things for people that have that inflammation of the esophagus would be changing their diet. So things like eating soft liquid foods, avoiding certain acidic foods, um, things like that, just to make it more comfortable for them. Let's see. I think for the radiation, the anemia is probably depends on the area. So like if it's like hitting some of the hard, oh yeah, yeah. Yeah, I think that was mentioned, yeah, because of the pancytopenia. I think if you do radiation to like long, like a lot of like long bones and stuff, it can, because it starts affecting like the red bone marrow, the areas where but yeah, let me see. Yeah, the soft diet, bland, soft diet. So just some patient teaching there. So what are some of the teaching after radiation is done? Or I guess like after, I do like the idea of like keeping things marked. Yeah, so of the area is going to be more sensitive to the sun. So avoid sun if possible. You can use sunscreen and stuff. Well, depends, but you can use sunscreen, I think. No lotions, but I think sunscreen's fine. Photosensitivity, yes. Soft, loose clothes. Here, let me double check that. I mean, if he said no, then it's no. I'm not seeing where it says that it's not indicated. Okay, so if he said that, then go with that. Yeah, I mean, I'm kind of seeing that it seems like it's considered fine, actually. What's in it? I guess it depends what's in it, sure. Some places say ask your healthcare provider. Looks like, huh. So maybe things might have changed since he wrote that. It seems like it's not, seems like it's a little bit different. Yeah, I get that. I think maybe the understanding of it's different from when he made the PowerPoint and stuff. I'm seeing more support for sunscreen at the moment, but just go with what he said. Uh, yeah, definitely. I think there's some things to avoid, but Just go with what he said on that one. Yeah, I think that if the MD thinks it's fine, then it seems to be fine. I think it's becoming more common, I guess, for them to be okay with it. But if he said, yeah, I think, yeah, if he said no sunscreen, then just go with that. Yeah, just like general stuff here. Some other things with general concepts. Tumor lysis syndrome. This would be, does anyone remember this one? Things to think about for the radiation. Yeah. So essentially we are destroying that cancer so much, we're breaking down cells. If we're breaking down cells, we're releasing potassium. So hyperkalemia is the main thing here, and it's hyper uricemia, so hyper uric acid release. So you're gonna wanna flush it out. So flush out, yeah, same thing as hemolysis essentially. Flush out with fluids and allopurinol for the uric acid. And then general radiation precautions, kind of, yeah, the standard stuff with that. Limit visitors, pregnant women, people under 16, if they're radioactive. But that'd be more like internal. Like if it's internal therapy, or internal radiation, or if it's chemo, or if they're, well, probably more like the internal. Just kind of things like limit visitors and stuff. Okay. Again, that's a solid background. I think the biggest focus overall for this chapter, though, is going to be on the surgical management. So that would be the difference between lobectomy and pneumonectomy. We did talk about it before. Now we're gonna break it up a little bit into some of the major differences between them, as well as some important things to always think about. So let's see here. Yeah, pretty much. So lobectomy, we're only really gonna remove a single lobe, lobe, not lobe. Remove whole lung. So your pre-op care, some of the standard stuff, MPO, informed consent, and we inform the explanations, expectations about the incisions, what to expect after using um, your incentive spirometer, turn cough, deep breathing, pain management, if they're going to be on tubes and stuff. And then there's the post-op. So this is the focus here. So you're going to worry really a lot about their oxygenation, of course. What's the best positioning for them post-op? So it's always going to be good lung down, exactly. So if someone has a right upper lobectomy, they're going to be placed on their left side because that's their good lung. So this is going to help to maximize gas exchange and stuff. Good lung down. So assessment of SATO2, we're assessing respiration there, like that. Good lung down. Yeah, good lung down. So from there, we also have things such as, if they need supplementation, so to supplementation if needed. We talked about IS already. If they're gonna be post-op, we're always thinking about early ambulation, thinking about things to prevent DVT. Yep, always thinking about that for post-op. Head of the bed up, at least 30 to 45 degrees. Pain management can be a factor. Pain medication. And well, I guess pain management rather than pain medication. This is important because some people might not want to do their IS because it hurts, but it's really important that they are able to do deep breathing and coughing and use their IS. So sometimes the pain medications are needed so that they're able to do so. So that's why that's an important thing. Okay. Ba-ba-bum. Let's see. So then with your assessment of lung sounds, lobectomy can have diminished, and pneumonectomy absent because it's just not there anymore. Turn cough, deep breathe. So what else might the patient have after one of these two? Especially the lobectomy. They'll have scars, sure. What about actively there post-op for a more so with more definitely more so lobectomy. Yeah, the chest tube. So this would be management of the chest tube. So more likely with a lobectomy. Nothing really to drain with a pneumonectomy. Yeah, a chest tube. So more I would say relevant for a lobectomy. And even if they have the chest tubes, we still want them to move around with the early ambulation. So you might put the chest tube on like the water seal. Chest tube more for pneumothorax. Um, I mean you can use it for both. You mentioned the mediastinal tube for lumpectomy. Oh, he didn't say any of that in our class. That's crazy. I don't actually don't know. Don't know the difference honestly. Let's find out. Huh. Seems like they're pretty much the same. I think it might be a difference in the way it's where it's placed. Don't worry about the semantics though. Cool. I did not know the difference here. Yeah, don't focus on the semantics. Just kind of generalize it. We'll do that. Mediastinal tube. Yeah. So this one's more relevant for lobectomy. More relevant for lobectomy because you still have the lung and there's still stuff to drain. So pneumonectomy is not typically gonna not gonna be, there's nothing to drain, so it's not really gonna be there. We'll go over more detail on the chest tube tomorrow, or if we have time. Probably will have a little bit of time, but so far our pacing has been pretty okay. But that's the something for a different day, I suppose. Do we have to do any wound care for these surgeries? Um, with these ones, they should be closed up and approximated, but it's something to definitely assess. So definitely we're gonna be doing that. So uh probably we're gonna look at the incision, but it should typically, yeah, you're gonna monitor the site and stuff, the dressing, but it should be closed. So let's kind of just look at it. Menectomy scar. Obviously this is a healed one, but that's kind of the idea. It would be closed up, approximated, and we'll be assessing it for signs of infection and whatnot. Too much bleeding, purulent drainage. That's the thoracotomy. Uh, but yeah. Ooh. It won't be, it's rarely gonna be like the ones you do in Skills Lab, where it's like fully open like that. Position care, no, assess the site. He also mentions if the patient needs to be ventilated, prevention of ventilator acquired pneumonia, the VAP guidelines, that's important to keep in mind both now and also for the future. It comes up a lot, actually. It comes up like at least in 2 tests past this class. So this will come up again because if someone's intubated, it comes up for critical care again because that happens there. So prevent infection both from incision as well as from ventilator. That's the VAP, ventilator acquired pneumonia. So yeah, so we mentioned the chlorhexidine, oral, oral care, the PPIs, or even the H2 blockers. So H2 blockers example would be the famotidine, anything that ends in the dine. PPIs would be things that end in prazole, like omeprazole. And yeah, that's there to prevent acid reflux. So yes, you're always going to want the head of the bed up, probably like about 45, 35 to 45, probably closer to 45. High Fowlers. Uh, the PPIs help to prevent and reduce acid reflux because if they are having acid reflux, then you can then swallow it back into the airway, aspiration pneumonia, yeah, that's the PPIs there. So that's the purpose. And if they're gonna be sitting there, you can prevent like peptic ulcer disease. It's like ulcers. Head of the bed up. Um, there's like another important thing if they are on ventilators. That would be that they're usually sedated. But you do want sedation medication, so you're gonna s- take them off the sedation in order to give them the ability to breathe on their own as well. They're not gonna be always sedated. So these are all important and good to keep in mind. Something that I noticed that's actually not listed here would be I think oral care. Here they say daily. I think for us it was like every 2 hours. And then there's suction PRN. It's like suction PRN every 2 hours. So it's if they don't have anything 2 hours later, you can check again. If you do it 2 hours later, you can check again, but you don't do it like continuously every 2 hours. It'd be more of a if it's going down, you do it, and then even if it's still bad, kind of wait another 2 hours just to prevent going in too much and causing damage. And then the oral care, it says daily on I guess this PowerPoint. I think we have the list come up again for ventilator acquired pneumonia prevention, the bundle. And I think there it says 2 hours for the oral, every 2 hours for the oral care, but I could be mistaken. But for now, this should be good enough. But definitely you do need to know this. I would say you definitely need to know this. And keep in mind antibiotics, prophylactic antibiotics is not something that's done, not typically part of the protocol. Okay. I'm gonna go ahead and just real quick take a look at the bundle. just to see if there's anything else that's good to keep in mind there. Yeah, we were told oral care every 2 hours. Although here, I mean, correct me if I'm wrong, your PowerPoint said daily. It just said daily, I think. I don't know if you guys are checking or not, but I believe that's the case. So this should, again, this will come up a few times, multiple times. So it's something to keep in your brain now and keep in the brain the time frames. The time frames are important. You don't want to get got because it's like the right answer, but the time frame is like wrong. But that's the basic things for this. Again, I think this is important. Any questions on lung cancers? I think if we go back, the general focus is understanding. Weird. Okay, that's very interesting. Was that like a answer choice you gave? It's very strange. He told our class the opposite. He said it's not usually part of the. Oh, really? Did he actually change something? That's crazy. I see. For the VAT, maybe this was mentioned in class, and I kind of just added it in there. That might be something that, yeah, might have been. Okay. Well, the point is that it's important to know. But I'm gonna go back up at everything we went through and just kind of see what I think is the most important out of everything. The knowing the difference between the two. Treatment, this is important. Treatment, knowing the causes is good to know. Some of the manifestations is good to know. Difference between these is good to know. That's funny. He's funny. This definitely know, when it's bad, the airway obstruction, definitely know that. Know that there's the potential to cause the shoulder pain. This is just a good reference. This is not the biggest focus on. Definitely know the difference between why like a chest x-ray is not as effective as opposed to like an MRI or CT scan. Your PET scan is for meds. Your bronchoscopy is where you can get those biopsies, which is your going to be your gold standard for determining how your lungs are doing. Some of the other tests that are good for lungs, like your ABGs, sputum cultures, if they're having sputum, and see if there's an infection happening. If they have pleural effusions, we can do thoracentesis, bone scan for bone metastasis. Bronchoscopy honestly has very basic post-op and pre-op. Your MPO, informed consent, gag reflex afterwards, vital signs assessment. The complication, superior vena cava syndrome, know how it leads to swelling, and that swelling leads to potential airway obstruction. The paraneoplastic, again, focus more on the end result, more so than like the names of each specific hormone, I would say. Talked about that. The basic review of chemo and radiation. Chemo is systemic, radiation is localized. Some of the basic signs and symptoms of or the kind of side effects more than signs and symptoms, but side effects of chemo, pancytopenia is probably like your biggest thing, nausea and mucositis. Some of the stuff after radiation, soft loose clothes, avoid the sun if possible, pat things dry, avoid lotions and stuff. The understanding about tumor lysis syndrome, how you guys were on it, so not worried about that for you guys. The hyperkalemia, you can flush that out. Understanding for sure that with the pneumonectomy, you're not going to have the breath sounds because there's no lung there. This is key. Good lung down. So if someone has a left-sided pneumonectomy or a lobectomy, they're going to be placed on their right side because that's where the good lung is. So the non-operated side, that's the side that they're lying on because that's the good lung down. Um, for sure, you should be expecting that they're going to be using their IS. They're going to be turning, coughing, and deep breathing. They might need pain management in order to do so. So that's, if the patient is refusing to do this because it hurts, give them some pain meds. They have an incision, so we're always assessing that. Lobectomy, more likely to have, I guess, specifically the mediastinal tube. TCDB, oh, sure. I guess that's something that abbreviation they push on us early, but I guess if you're coming in the middle, it's like a new thing. So the turn, cough, deep breathe. No worries. I mean, you're coming in from like the halfway point. Yeah, but they pushed this abbreviation on us really hard in the first semester. IS incentive spirometer. Uh, what else? What else? What else? Yeah, I think this is important to know that head of the bed should be up. Why they give these in order to prevent aspiration pneumonia, acid reflux that can lead to aspiration pneumonia. The chlorhexidine oral care. You need to give them a sedation vacation so they can breathe on their own. That's pretty much it for that. All right. So next up is the laryngeal cancer. So this is the cancer of the neck more than anything. The head and neck cancer. So overall, it's going to disrupt your breathing, disrupt how you eat. It's going to have a change on your appearance, self-image, and your voice. Your voice is going to be a big thing because depending on what kind of surgery you need to do, then you might lose your voice entirely. But it is curable if caught early. And just like lung cancer, it's able to spread to different parts of the body, just like every cancer. So, what are some of the warning signs? So, just like lung cancer, there's some signs that are potentially kind of vague, but they're warning signs for of the laryngeal cancer. Let's see what we got here. Recurrent sore throat, localized tumors visible, mouth ulcer not healing. Yeah, so I'll read it from top to bottom. Oops, open the new tab. Like a non-healing mouth ulcer. I mean, herpes goes away temporarily. Non-healing mouth ulcer. Hoarseness. So that would be kind of like the sore throat, hoarseness of the throat. The white patchy lesions. Yeah, so that's the leukoplakia. And there's also like a erythroplasia, which is like red patches. It would kind of look like I was thinking the same thing. Kind of would look a lot like the oral thrush. Let's take a look at what that looks like. Think no, it does actually look noticeably different than the thrush. It's less hairy. It does just look like patches rather than candidiasis, which looks you can tell it looks yeasty, right? Let me see what else you guys mentioned. Yeah, you guys mentioned the patches. So the leukoplakia, which is the white patches on tongue, the velvety ones, the erythro erythroplasia. So that's velvety patches. Yeah, we talked about the hoarseness. The neck lump. Josh mentioned the neck lump a little bit ago. Oh, no worries. Neck lump. Yeah, the change in denture fit. That one's like that one always stood out to me. Like, I mean, I guess it makes sense, but I didn't like. It's like kind of random, but not really. But it's kind of random. Other things could be like difficulty swallowing, so dysphagia, difficulty swallowing. The throat and ear pain. So I guess, oh, surprisingly, I didn't write it already. A lot of these things. So again, if it's something happening, cancer in your neck area, we can uh kind of think about like shortness of breath, stuff like that. And the risk factors, what do you guys think? Yeah, the classics, smoking, alcohol. Oh, pretty much, yeah. It's always them. Overuse of voice. So if you're overusing your voice, potentially causing damage to it, um, you end up causing a bunch of scarring, and sometimes that can lead to cancer as well, which is kind of like a similar rationale for why, if you guys remember, GERD, that can have increased risk of esophageal cancer because of the acid causing damage to the esophagus. So over time, just continuous damage can lead to cancer because it's going to constantly be replacing itself. And sometimes, if you're constantly replacing yourself, you increase the risk of having a messed up, creating some messed up cells that can then spread cancers. So same kind of logic there. Straining the voice too much. Yeah, smoking alcohol together is even bigger risk. But these are just the general. Diagnostics, so some of these are going to be very similar to the other one. So chest x-ray, CT MRI, so detect masses. Same logic that the CT MRI are more accurate because they're able to get more, able to assess for things that are going to be more, the more tiny. Yes, so the laryngoscopy, the endoscopy, laryngoscopy. So this is gonna be your procedure to visualize, take biopsy. So this is gonna be your gold standard for that one. Yeah. So biopsy is always your gold standard. And yeah, this one's laryngoscopy, so it's not as far in because your larynx instead of your bronchi. Uh, similar to the other one. We talked about it already, so I'll just mention it. Bone scan, PET scan. So a lot of the same stuff. So if you know one, you pretty much know the other one. Similar to the other one, it's your goal is to, get rid of the cancer, preserve as much as you can. Um, and very similar to the other one. Obviously, oxygenation, respiratory is going to be your main thing, but aspiration is another really key thing, especially post-op. One more than the other, depending on which type of surgery you have. Aspiration can be a really big deal because it makes sense because it's all happening around that same area. So we are gonna do radiation and chemo, especially chemo if there's metastasis. But what are some of your concerns with the chemotherapy, sorry, chemotherapy, radiation on happening in that area? Yeah, so we have xerostomia, which is like a dry mouth from lack of saliva. So like a dry mouth due to lack of saliva. Essentially, your radiation is killing some of the cells that make your saliva. So you're gonna have that dry mouth. So dry mouth, xerostomia. So we talked about that. What else? Esophagitis. Yeah, pretty much the same thing. What about like a really major, scary one when you're putting stress on like the neck area? You can increase your hoarseness, yeah. So that can also lead to hoarseness, trouble swallowing. Anyway, if it causes damage, I could see it causing varices. Like that's like the void shaping the neck. So hoarseness, difficulty swallowing, because again, uh, you're putting radiation there. So if you're putting radiation and stressing out that area near your neck where you swallow and where your airway is, yeah, that's Ashley got that. So we're looking for neck edema. So we want to assess the airway because our own interventions might lead to airway obstruction as well. Cool, cool, cool. Let me see what else. Void shaping the neck. I can imagine that, yeah. So it might be some things. Someone said the muscle pain, the muscle relaxants. Yes, so that could be a good thing. So um, muscle pain in the neck, give muscle relaxants. See what else we got here. If someone does have the dry mouth, what are some things we can try to do to kind of alleviate that? Yeah, like hard candies, maybe some of those, yeah, water, maybe, carry like a water bottle with you or something. Tell them, just have water bottle with you. Gum, I think gum is good too. Some of those like dry mouth, artificial saliva stuff as well. I mean, if it works, then if it works, it works. In general, resting the voice is good. Avoid, yeah, we said avoid. I guess just avoid messing with that space. So avoid shaving, avoid. We talked about already some of the general stuff like no sun, no lotions unless it's prescribed. Avoid tight clothing. Don't wear what would be a tight thing on your neck, like a collar, like those really tight like dress shirts. Oh, a scarf, yeah, turtlenecks. What's a halter top? Oh, okay. Oh, like this one? It's just I think it's just thinking about like irritation and stuff. I think you don't think I could rock this? That's crazy. Okay. Well, let's see what else. Just girly things. I think the idea of the lack of lotion is that it can contain some stuff that's irritating to the area. Wait, hold on. What is this? Oop, sorry. My thing died. There we go. Um, oh, by the way, just random. I was just checking my email. Did you guys get for the people that bought stuff? You guys, I got an email today saying it got shipped. So I was wondering if everyone for the customing people that bought shirts and stuff or hats. All right, cool, cool, cool. So it looks like it's starting to get shipped and stuff. But yeah, so that general idea would be some products can irritate the skin, and if they're getting radiation there, that skin is more sensitive. So it would be ideal that the doctor approves it, so it's not really irritating and stuff. But basically, just take care of that area. So avoiding the sun in that area, try not to shave. I guess you're growing out your neck beard or whatever. I guess if it's in your neck. But other than that, that's kind of like the major thing to think about here is your radiation. So when it comes to this, we talked about your warning signs. So I think that's good to know. Your management, I think the radiation stuff is good to know for sure, especially like your neck edema. Um, if someone does have dry mouth, get them that like water bottle or whatever. Um, hard candies, water, gum. So, what else here? Yeah, and then the rest is just going to be focusing on the surgery. So pre-op is going to be your standard pre-op. Is really not too crazy. Standard MPO, informed consent, blah blah blah. But there we do have two different types. So laryngectomy, so that means we are excising the larynx. So either we're completely excising the larynx. They do a swallow study after. So I mean the larynx is different from your esophagus, but some of these I mean it makes sense, but one it would make sense for one more than the other. When they get rid of the I guess I'll have you answer. One of these doesn't really have to worry as much for aspiration. It would make sense on one of them, but not the other. Yeah, the partial one's a risk. The total one, you don't have to worry. And I don't know if there's a picture that goes along with it, but what they do is that the esophagus is completely separated from the airway. They remove your glottis, so maybe we can take a look at that. Total laryngectomy, post-op larynx. Let's see. So, when they do a total here, you can see that, yeah, likely you'll have like a stoma and stuff. But I think even from like, um, that perspective, like you can no longer swallow into your you can no longer swallow into your trachea because they're no longer within that same area. Your glottis is gone, and you're likely going to be having a what do they call that thing? Laryngeal stoma. So you literally can't aspirate anymore that way. Just gotta be careful not to, I guess, I don't know, like I don't know, maybe you can get something down. I mean, if you get something in here somehow, you can't really drop stuff in there though. That'd be one way. I think so. I think so. I mean, yeah, it would be like all that water directly going into the trachea. That'd be pretty bad, actually. It'd be worse than just like swallowing some water. It's like full connection in there. It's completely open. Yeah, yeah, yeah. No, yeah, yeah. They have the covers. But I'm just saying, like, it kind of they have this. Yeah, they do have the covers. Yeah, you're literally giving them subscribe. But yeah, they don't just have it out in the open. They do have the covers and stuff. And depending on um the person, um they have like the little voice box things as well that they can um like the little robotic voice electrolarynx, that's what it's called. Damn, that's cool. Yeah, so that's like a thing. I think he had like a computer thing. I don't think he spoke with because he had I think he couldn't even move his mouth at that point. He was just moving his fingers on a computer. But I think at some point I think he might have. But I think his thing started with like his fingers first. I don't think he had ALS, but I think he had something similar. His eyes? That's crazy. But I think the sound will be similar though. It will be like that Microsoft Sam sounding thing. But yeah, it's like standard pre-op care. And then there's the total laryngectomy partial. So one of the key things, like we mentioned here, is that the whole shebang is gone. The whole voice box is removed, and you're gonna have a loss of normal voice. So there's really nothing you can do about it. You're not gonna have your normal voice. So that can be a thing that affects people's mental health and self-image. I believe, yeah, you just will not have. I think you might be able to do certain things. Like I think you might be able to like burp, like burp words out, but it will definitely not be the same. Like you definitely need yeah, I think you need like that artificial voice device, and there's nothing you can really do otherwise. I don't think there's no ifs and buts. You just kind of have to do that. Um, yeah. Another again key thing that we talked about would be the fact that because they took that part out, they straight up fully separated your larynx and your esophagus. They removed the little glottis. So the glottis is that little flap that would be that like little flap that can close to separate to make sure that you're not swallowing stuff into your trachea. But that's completely separated. So when they do take out the whole thing, the good thing is that there's no aspiration risk because it's separated now. So separated the airway from esophagus, so you don't have to worry about that. So that's a good thing. But yeah, we will need a artificial voice device. And another thing to keep in mind is you can no longer breathe through your nose or your mouth. You become entirely reliant on that artificial new airway. So you become a total neck breather. Oops, neck breather. So you cannot use your mouth or your nose to breathe. So that's a bad thing. I can't imagine how uncomfortable that is. When my nose is stuffy and I have to breathe through my mouth, I almost feel short of breath. It's just not great. I cannot imagine. But this impacts some of your senses, so sense of smell and taste are not gonna be doing too great. A lot of your taste comes from smell as well. So something he mentioned was that you could technically like do like a yawn to smell through the stoma, the polite yawning. Yeah, I can't imagine. Yeah, but it's definitely something that's definitely gonna impact their mental status, their mental well-being. But yeah, the general stuff. It's probably just pre-op care, pretty standard. The um, priority becomes airway, pain. There's gonna be tubes. There's gonna be care of stoma if they have it. Self-care, like self-suction. But yeah, so that's definitely like a crazy thing, and you don't need to know too much about the esophageal or the laryngeal stoma. Just need to know it's there, and that you just need to know that the person will have that from now on with the total laryngectomy. And it is not quite the same as the trach. The trach is a little bit slightly different. The trach is you create an opening through the neck into the trachea. The laryngeal stoma is essentially taking part of the trachea and kind of like we saw in this other picture and moving it to that area. So the difference between them would be one of them can be permanent, one of them can the tracheostomy can be temporary as well. Where's the picture? Why do you lie to me? Oh, there we go. You can see here the trachea is just straight up going outside as opposed to like a hole going into there. It's now directing towards the outside. But you don't need to know too much more about the little stoma thing. But then with partial, you guys mentioned this, so I'm just gonna talk about it. The partial one, you have that risk of aspiration because it's still you still have part of your larynx, and you also kind of contrasting is you may have normal speech and more swallow function. Well, you have more swallow function, may have normal speech. There's going to be a risk for aspiration because the glottis is still there. You can imagine it's going to be kind of awkward to speak like you used to. It's going to be awkward to eat like you used to. So greater risk of aspiration. Stuff is not really the same once it's been operated on. There's also a chance of swelling and stuff. So localized swelling possible, which can affect airway because you just manipulated um, that area there. So if there is localized swelling there that can affect your airway, what can we do to until that swelling goes down? And yes, Josh mentioned it before, but yeah, you will have a swallow eval. Is there no swelling after total? I mean, I imagine like the area itself will be swollen, but it's not to the same point compared to here. Yeah. So what about the ice packs and the anti-inflammatories aren't doing good enough? Like basically, I guess it's kind of like last resort. Um, this person won't have a stoma, but they'll have something else. They have the trach. Yeah, like a temporary trach. Can have a temporary trach in the meantime. So all your trach stuff applies. So you're gonna want that obturator at the bedside, suction at the bedside, O2 at the bedside, an additional trach just in case it comes off, it comes out, and the swelling is so much that the old size doesn't fit anymore. So maybe you can have one that's same size, one that's like half a size, one size smaller. So if the little hole is more has been more constricted, then you don't have to like find the smaller one. You just have one just in case as a precaution. So that's important. So definitely know that that temporary trach, you need to have the obturator. So if the trach falls out, you need to put the obturator in, and the obturator's purpose is there to so that you can insert the trach without causing damage to the lungs, and then you have to remove the obturator because otherwise the obturator will be um obstructing the airway. So obturator and attempt to reinsert. And you should know suctioning, with sterile gloves. Oops. That's kind of like the main thing here. Be that this person has a risk for aspiration. You need to do a swallow eval, temporary trach here. They can have normal speech. So someone comes in with a partial laryngectomy, or they're about to get the surgery, and you have like a question where like I don't know, like let's say like the patient is crying and they're like, oh no, I can't, I'm gonna lose my voice entirely. Then maybe one of your patient teachings is explain to them with a partial, they may be able to have the normal speech because they get to keep um their voice box, part of the voice box. That could be like an example of like maybe like a Kaplan question. That sounds like something that could come up. But yeah, the main thing, aspiration here. This one, not so much with the aspiration because it's separated, but they will rely on that hole in their neck, and they will lose their normal voice. They will need an artificial device. Taking care of the stoma. Make sure you know about the obturator. And you guys have probably a lot of you did your suctioning for your CPE. So I'm sure you guys know all about that. Yeah, for sure. And I think the very last thing here is the radical neck tissue flap care. So you can have a radical neck, so radical neck reconstruction. So that's another thing that can be done here. Radical neck reconstruction. So yeah, pretty much this whole chapter is airway is your priority. The entire chapter, pretty much for everything. Even post-op, it's your priorities. You're manipulating the area that can cause airway obstruction. You're putting radiation into the area that can cause airway obstruction. So everything here is airway obstruction. Always airway. And here's kind of what that is. So focus is going to be airway. Pretty much always going to be that airway there. Airway and perfusion. So airway and perfusion here. So here it has that. Maybe we can take a picture of it. That could be good. Radical neck flap. Holy crap. But it comes out looking pretty good after. See if I can find one. See, that doesn't look too bad, right? Well, I think that might be prior. Ah, good. All right, cool. Yeah. But yeah, you're kind of worried about it's a graft essentially, so you're worried about, you know, the airway, of course, but the perfusion, making sure that the area is perfusing good, because otherwise then that neck flap is, you know, kind of dying. So that's the main thing there. So what are some things to report to the surgeon there in terms of that? Yeah, he talked about the little leeches. Kind of just, yeah, any changes to circulation. So that includes things such as probably just, yeah, I like that, like swelling and redness, no pulse on the flap. Essentially just, yeah, you're gonna be monitoring like yeah, pretty much like anything that affects perfusion. So temp refill stuff, color, temperature, um, color and temp are abnormal. Yeah, there's purulent drainage. Pretty much any, yeah, pretty much the stuff that makes sense. Um, infection, purulent drainage, swelling, color, temperature abnormal. So it's cyanotic looking, it's dusky looking, it's cold, or the rest of the body isn't. Um, yeah, and then I guess this should actually be, this is just for the radical. So let's just kind of do that. And then this would be for the laryngectomy, home care. So for the people that do have wait, for the people that do have that stoma, some of the things that they have, yeah, the self body image is a big one. We talked about a shower shield or like a shield stoma guard to protect. Pretty much don't go swimming because you're gonna die. You're just putting a whole bunch of water into your little trachea. Yes, barrier cream. So utilize skin barrier lubricant, skin barrier creams on stoma, clean with soap and water. Another thing, maybe, yeah, you can humidify the air. That can help humidification of air can help to thin mucus secretions. Yes, so that's another one that I think is really important is the medical bracelet. So, I mean, I'm sure people can tell, but I mean, I guess people might not know. They might see it, but not really think too much about it. So, the medical bracelet to um, let people know that they are a neck breather. So that means that CPR breaths are done through the neck. Because putting that in the nose isn't really gonna do much because that doesn't go there anymore. And then how do they eat? So, well, initially they're gonna be MPO. So this might be someone, and it might be MPO for like a few days. Like, so this might be someone that might be a recipient of TPN or something. Yeah, but obviously we're gonna try to we can utilize like an NG tube as well, because then the what's it called? Um, yeah, exactly. So we're probably gonna do enteral feedings first, just because it's the esophagus is still working, the stomach is still working. So enteral feeding um first. So NG tube, G tube before TPN. So TPN might be appropriate, but the enteral feeding, because that whole part is still perfectly functional. Not like their nose does anything else at this point. Their nose doesn't really do anything other than like be a passageway to the esophagus, I guess. He said mention the supraglottic swallow method. Oh yeah, so that's like what is it? Is that the one where it's like you breathe in air, swallow or take a bite, and then breathe in air, so something like that, right? It's like sit up, clear the throat, take a deep breath, take some food, hold your breath and swallow twice, release your breath and clear your throat. Yeah, a whole lot of deep breaths. And then there's also the esophageal burping and stuff. So that would be like speech rehab. I'll just post it because I don't think it's too emphasized, or like it's not too relevant for a lot of the stuff here. Um, but for sure, aspiration, risk, if partial. You're gonna need to do a swallow eval. This is one of those scenarios where you don't delegate the feeding before supervising the first feeding because they need to do a very specific thing. And then for speech rehab, I'll just kind of post it. I don't really, it's just there for your own learning. Total laryngectomy will not be able to talk at all. So this is for partial. Um, I guess partial. Yeah, partial can do the esophageal speech, I guess. That's the the burping of the words. This is just the kind of just like a more extra info, not as emphasized. I think I would say for sure aspiration. Oh, aspiration is gonna be your big focus. Swallow evals. You go enteral first. Probably the home care is good to know for sure. The stoma guard and stuff. But yeah, that's the main focus on this. Any questions on anything so far? Or I guess that's everything. We can maybe do a little bit of um like a little bit of the other one. How was the respiratory exam? Let me see if I can remember. Oh, I guess I don't have to remember that much because for some reason our thing is still up there in my canvas. I don't recall many, no, if even if even there was any, if I'm being honest. But even if there was to be, it would be you would get like the paper telling you what numbers to plug. Like it's not like you don't memorize the hospital policy. Everything is different depending on the hospital or if pharmacy does it. So like you would get a paper that tells you the algorithm to follow. You're not memorizing any algorithm or anything. Oh, the ABGs. Do I have? I think that I might have that section in the next. Would be tomorrow's, I guess. But for that, you don't. It's not as much. It's not super hyper detailed. At most, you just have to be able to tell if something's acidotic versus alkalotic, respiratory versus metabolic. It's not too much on. Yeah, that part's not. Yeah, basically, yes. That's pretty much it. If at all, if I'm being honest. I don't think compensations. No, not for this one. Maybe for 240, but not for this one. I don't recall. Let me take a look. If I recall, I think. Oh, I guess I can look at the class average too, because apparently this thing's still in here. Uh, okay, my class average was. Is that a 40? All right, cool. Class average was like an 85%. For me, I think this was my worst quiz, but again, it wasn't too bad. I think the midterm. How good was the midterm? The midterm, we had an 86% average. For me, this was the hardest test, the respiratory. And then, is that all the tests you guys have, really? You have midterm, respiratory, and just the final? Is that it? Oh, no, there's a cardiac renal. Oh, yeah. So, cardiac renal, I think that was everybody's hardest test, but I, for some reason, did really good on it. The class average on the cardiac renal one's a little iffy. I think it might have been just the wording on the cardiac one. I did really good on it. It was actually my best test. I don't know. I don't really know why, but yeah, that was the general population's hardest test by like a considerable amount. But if a lot of the issue was like the wording, and then they did like a really heavy adjustment after. So possibly by the time you guys take the test, they maybe ironed out some of the issues with the wordings and stuff. How good was our final? Let's see. Our average for our final was like an 83%. Our cardiac renal average was about an 82%. And our respiratory average was 85. And then I think the midterm average was like an 86%. So generally around that ballpark, the average student in our class was getting, none of these tests ever was below 82%. Oh yeah, for sure. Any questions on this, by the way? Anything here? I don't think we have time to do the whole entire next one, so we'll probably will split it off into the two halves. But I can give you guys a preview. Oh, would they create a esophageal fistula? Don't think they do. Like, what do you mean? Because that implies that they're putting the trachea inside of the esophagus. Under for speech rehab. Hmm. Actually, I don't know actually. Let me take a look. If regardless, it's not really. You said she, so I'm guessing it's Brooks. This is Brooks audio, maybe? Is that what you mean? Oh no, you said it's not she. Where did I get she from? Yeah, I don't see why that would be a good thing. No, it's from Robin's PowerPoint. Interesting. Let me take a look. Oh, regardless, it's not important, so don't worry about it. But let me see. Yeah, that might be what I figured. Yeah, it's to help facilitate speech. But then is there must be some reason for 'cause typically that's not a good thing. That's if that's occurring, it's for not good reasons, usually like at birth or because of maybe I could imagine it happening with like someone with acid reflux, like over time maybe it completely erodes the esophagus and it causes a fistula. But otherwise, yeah, looking like the idea would be to do so in order to facilitate speech, but I don't think that's a good idea. So I don't know how that's managed at all, but that seems to be, how would that be managed? Wow. Maybe that person would chronically have to be like on enteral feeding, like through other means. Yeah, I think that's a thing. Well, that's crazy. Wow. Basically don't worry about it, but that's kind of the information I seem to find would be maybe it might be a little bit of a trade-off. You maybe get more speech, but you need to be on a feeding tube. Damn, that's insane. Huh. Yeah, that's it. That's very interesting, but also don't worry about it. Yeah, I'll give you guys the PDF and then let me see. I'm gonna bring up yeah, just to get a preview of what's to come. And then I'll give you, do you remember any Kaplan on the respiratory quiz? Probably, yeah. I believe yes. Maybe like 4 to 5. There usually is. especially if it's a Robbins. Robbins uses Kaplan. Like consistently, we'll use Kaplan. Where are we? Boom, boom, boom. Week 4? Yeah, I guess technically. Yeah. So here would be, this would be for tomorrow then. So we'll be going over tuberculosis. There's a lot of extra info here that we can kind of put down or like decrease down because it's a lot of extra info that you don't exactly need like to know. Like a lot of the patho is a little bit extra. So just down to the basics. Diagnostics, the management, and then the rest of that is going to be focusing on like pulmonary embolism and the pleural space in general, some thoracentesis stuff, some chest tooth stuff, and then ABGs will just kind of be like how to read it. Again, it's not how to treat it is not really for this class. It's just kind of how to read it. So if anyone has confusion on how to read it, then we talk about that. Otherwise, that's pretty much it. You don't really know too much about ABGs other than that. You're not gonna get a question on like interpret this and then also treat it. Like that's not gonna be happening. So your main focus is gonna be on your pleural space stuff, tuberculosis, more so than the ABGs, and then the cancers here. But yeah, I'll give you guys as a doc and as a PDF. And then yeah, we'll end a little bit early, I guess. What time did I start? I guess it's been 2 hours. Ba-ba-ba. Any questions on stuff here? Yeah. I'll see you guys on th tomorrow. Tomorrow and then Thursday. I'll be there for your skills lab on Thursday. Well, when is your CPE? Oh, did that already happen? It already happened, didn't it? The central line one? Oh, you guys are done. How'd it go? Pretty good, right? Yeah, figures. Bet. Cool, 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 cool. So now you guys did all of that. Did the retakes for the first CP happen already? One recording.